Hey Janice, can you hear me? I just unmuted your audio.
Yes, I can hear you fine.
You may have to activate it on your end, potentially.
Were you not hearing me?
I can't hear you.
Oh, okay, okay. Let's see. Why not? My webcam's plugged in.
Audio. Okay, so Janice, it says you're talking, but I can't hear. I wonder if your microphone is enabled on your computer.
Oh, you know what? Might not be plugged in.
I'm gonna try calling you real quick, Janice.
Okay. Okay, that's probably easier. Okay.
Why? Oops, let me mute that.
Yes. So, but yeah, now I just changed over to the other one, and that doesn't seem to help. So it says that my webcam, which is what should be plugged in, is the one that's working, but my light's not coming, I guess because I don't have a camera. But I mean, I have a camera. Okay, so I could, yeah, you can't hear me, right? Except on the phone. Okay. 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 I know. Okay. Yeah. Okay. But I think, and then you can hear me on the computer. Great. Okay, let's try this. Okay.
Okay, can you hear me?
Oh, I can.
Yep,
I can.
I think so.
And I hung up on the phone, so there's not a big echo.
Janice, can you hear me?
I can. Yes. Can you hear me now?
You don't want to do that in your heart.
No.
I got you. Hold on. I'm going to set the audio so it's. Sorry, bear with us. We're just going to update the audio real quick.
Okay, that's fine. Thank you. Wow.
So we're going to do output, internal speakers. There you go. And input. There we go. Okay, now.
Hopefully. I am unmuted, so
unmute someone in the group.
Let me see here. She is unmuted. Janice, can you hear me?
I can hear you fine. Can you hear
Okay,
me?
I cannot hear her again.
Settings on the audio is. This is it.
Okay,
Now you're good. Now you're good. Just don't click it.
can you hear me?
I can hear you fine. Can you hear me?
Woo! Yes, all right. Sorry, guys.
Can anybody else hear us? That's a question.
If someone can, there's a chat feature on the far right control panel of the GoToMeeting feature. If anyone can type in there letting us know that they can hear me, Laurel, or Janice both, that would be fantastic and a super big help.
Well, that's depressing.
I don't see anything yet. Oh,
And
okay, Joanna, I see Joanna is in the questions. She's saying we can hear everyone. Okay.
Great.
And Sydney and Monique and Jordan. Okay, awesome. Cool, cool. Let me, guys, technology is always fun. It always is something different every single time. So I appreciate you guys bearing with us. And I'm gonna get this geared up. So, Janice, are you going to be kicking it off, or are we waiting?
Yes.
We have 14 people on. Go ahead.
Is that Sapna?
We can kick it off if you would like at 6:35, or we can wait for additional people to join. I have 14 attendees logged on right now.
Great.
And I believe there were 15 registered. So.
Okay. And I know that there are more registered that didn't get the email about signing on twice. So there are people probably going to be popping on all the time. But let's see. Yeah, it is 6:35. Let me go ahead, just introduce you, welcome people, and then we'll go from there. So for the 15, 16, 17 of us that are online, welcome to the March Dallas Dietetic Alliance meeting. If you don't, since you can't see my face, this is Janice Scott, and the meeting coordinator along with Megan D, as we all know her by. So I'm delighted, really delighted to have Laurel speaking. She's a super Texas dietitian. So just kind of, I could read her resume to you and it would take us the whole meeting. But right now, she's currently the territory manager for functional formularies and is based in Austin, Texas. And that's where I first met her, but she's been around Texas a lot. She, of course, graduated from the University of Texas Medical Branch for her master's and her dietetic internship. Before that, she did her undergrad at the University of Texas of Austin, and she also has a bachelor's in psychology. You know, her work experience goes everywhere from a contract dietitian for HEB to the thing that I admire her, one of the things I admire her the most for is being a registered dietitian at the TIRR as part of the rehab facility at Memorial Hermann. And so I'm not going to carry on much because I want to let her talk about Blenderized tube feedings, and I know there'll be time for questions afterwards. So Laurel, let me give it back to you.
Awesome. Thank you so much, Janice. I appreciate that, and I always appreciate the opportunities for outreach and connecting with dietitians across the state and abroad. So as Janice mentioned, I am the territory manager for the state of Texas with Functional Formularies, who is sponsoring and putting on this webinar. And I've had the pleasure of meeting Janice in person in Dallas. And of course, through the pandemic, we're doing everything virtually now, hence the virtual meeting. But I'm glad that we have the technology to connect, and I hope everyone's having a great St. Patrick's Day and feeling lucky today. So We're going to go ahead and start. I will present everything, and we will have Q&A at the conclusion of the CE presentation. So please hold your questions for then, should anything come up during the presentation today, and we will address those at the end. So with that being said, if everyone can keep their microphone muted, that really helps with preventing feedback to the microphones, and hopefully we can enable that, or I can read through the questions down in the control panel feature. So please use the control panel to ask questions. You can send them to all or privately, or if you have a chat, you can put it down there as well. So with that all said, the title of today's CE is Blenderized tube feeding, a review of the current research surrounding whole food blended diets and their role in patient care. When Janice came to me with the opportunity, she said that the DDA was looking for more clinical informed CEs. So I hope this information is new and engaging and interesting information for you guys. So as a disclosure, I am employed by Functional Formularies. So today's learning objectives, first off, are to identify the top reasons that patients and caregivers are interested in blenderized tube feeding. You'll see that abbreviated as BTF throughout the slides. It's quite redundant to say it all the time, but here we are. The second learning objective is to describe the benefits of blenderized tube feeding based on the current research. Thirdly, you will be able to address common concerns of clinicians surrounding blenderized tube feeding based on the current research. And lastly, I would like for you to be able to describe the role of the critical role of a registered dietitian in guiding patients to use blenderized tube feeding. So to start off, the blank slate, what is blenderized tube feeding? So blenderized tube feeding simply refers to food and liquid that is pureed and administered through a feeding tube. In practice, this is an umbrella term that encompasses different types of blenderized diets. So when we look to the literature, we see different blended diets utilized in the literature. One of which is blended whole foods, using whole fresh foods with some type of liquid in a powerful blender such as a Vitamix or a Ninja. We also see blended whole foods utilized with a conventional formula as a base for more ease in meeting nutrient needs while still providing the benefits of whole foods. We've also seen in the literature pureed by gastrostomy or G-tube using commercial baby foods, which have often been mixed together with a conventional formula as a base, and that's typically been used for management of retching and gagging due to the cited increased viscosity of blenderized feeds. And then lastly is the category of commercially prepared blended formulas that are now available options on the marketplace. So we're going to take a look at the brief history of blenderized tube feeding. The use of blended foods to deliver nutrition and foster health was the first method of nutritional support. The history of enteral feeding goes back almost 3,500 years to the ancient Greeks and Egyptians, who were infusing nutrient solutions as enemas to treat various bowel disorders. Over the centuries, experimentation and research have contributed to a much greater understanding of nutrient requirements, methods to more accurately assess the GI tract, development of new materials to use in equipment, feeding tubes and containers, and also a better understanding of digestion, absorption, and the use of macro and micronutrients in clinical nutrition support. In the 1950s is where we saw the development of commercial formulas come onto the marketplace. These were very appealing due to the ease of use, the thought that there's decreased risk of microbial contamination with with conventional formulas, and also the precise nutrition information that would come from a conventional commercial product. There was debate in the medical community related to observed improvement in GI tolerance with whole foods and the cost associated with that. So another reason why we've seen this transition to more commercial products is, and often cited, they're more affordable. So in the 1960s and 1970s, with more manufacturing of commercial formulas and the greater availability of these products, the use of blenderized tube feeding steadily declined as a result. In the last decade, there's certainly a clinical renaissance occurring. More and more people are becoming interested in blenderized diets, and the request for blenderized diets is also increasing amongst our patients in the hospitals and outpatient clinics and after discharge from the hospital. So the use of long-term enteral nutrition has increased dramatically in the United States over the last 3 decades. About 500,000 children and adults in the United States rely on feeding tubes. And that number is only expected to increase as with longer life expectancies. There are well over 350 conditions and diseases that could warrant a feeding tube. So several studies have cited the increased interest in using blenderized tube feeding over the last several years, largely driven by the patient and or family's request for such a regimen. We're going to take a look on the following slide about why we're seeing this increased demand. So the first of which is that the population has a desire for a whole food diet approach, even those on feeding tubes, right? So there definitely is a trend towards more natural, holistic ways of getting nutrition, even for those that can't consume anything by mouth. There is an interest in the organic space as well. The USDA does cite that the demand for organically produced goods continues to show double-digit growth. Blenderized diets also allow us to adapt to food allergies, sensitivities, and or someone's preferred way of eating. Another cited reason for the blenderized diet kind of renaissance is improved tolerance. So we will definitely take a deeper dive into this, but improved GI function has been noted across a number of studies when it comes to blenderized diets. Better volume tolerance, decreased gagging and retching, and increased oral intake also. Psychosocial reasons are another cited reason for the increased demand. So blenderized diets help to normalize the feeding process for those on feeding tubes. Doing a blended diet allows individuals to be a part of mealtimes. Mealtimes, are a very social aspect of our day. So for those that are on feeding tubes, it allows them to be a part of that. They may get to enjoy cooking and being in the kitchen and not feel excluded in that. So there's most certainly some psychosocial implications here. It also allows individuals to consume and provide foods that are in line with their nutritional values as well. So, formula intolerance was one of the cited reasons on the previous slide. We're going to take a look at this. But what does formula intolerance look like? These are some of the most commonly cited reasons in the literature, but abdominal pain, stomach upset, diarrhea and constipation, so bowel management, gagging and retching, gastric reflux disease, nausea, vomiting, volume intolerance, feeding refusal. These are all very common things that we may be seeing in patients that we're managing enterally. And we will take a further dive into this too as we go along. So the Dietary Guidelines for Americans, the most recent DGAs were just launched for the 2020 to 2025 period. And they're not all that different than the previous 5 years. The Dietary Guidelines continues to emphasize a diet pattern that is rich in nutrient-dense foods and other health-promoting components. Yet the quality of standard formula options for those on feeding tubes has been far below the established recommendations for healthy individuals. The majority of commercial enteral formulas on the market today are largely comprised of inexpensive, highly refined ingredients. So heavily processed corn and soy ingredients like corn maltodextrins or corn syrup solids, milk protein concentrate such as casein. They're often devoid of fiber, fruits and vegetables, and other foods that have been implicated in that have been beneficial for helping decrease risk of chronic disease. So it can be argued that while conventional formulas are made to meet macronutrient requirements, they do little to promote, they potentially drive inflammation, and create dysbiosis in the microbiome, contributing to GI distress and also suppressing immune function. Of equal importance are the benefits that whole foods can provide as well. So the most beneficial attributes of a blenderized diet regimen include the vegetable sources of fermentable fiber, which helps to foster a healthy gut bacteria, better glycemic control, and better digestion. And plant sources of phytonutrients. Phytonutrients cannot be replicated in a semi-synthetic product. Phytonutrients come from vegetables and fruits and the plant sources within blenderized diets. And the phytonutrients have health promoting properties that may be protective against disease, helping to reduce inflammation and strengthen the immune system as well. So despite increasing evidence that implicates individual diet components of conventional formulas to chronic disease in an otherwise healthy population, the fragile population of medically complex individuals who receive the majority, if not all, of their calorie needs via a feeding tube has been largely ignored. So this citation here, and this quote comes from the Nutrients Journal from Professor Bingmark. He's a world-renowned surgeon and researcher from Sweden who has made great contributions to the hepatobiliary surgery area and the nutritional field in his career. In more recent years, he has spent time researching the gut flora, bacterial translocation, enteral nutrition, and critical care. So this quote here says that there is an urgent need for a completely new set of enteral nutrition formulas. The formulas presently used are only slightly different compared to the artificial formulas used in parenteral nutrition, made mainly to provide calories and to support a favorable nitrogen balance. New insights necessitate formulas made mainly or entirely with the goal of restoring homeostasis and inflammation and immune functions. So future enteral nutrition formulas should be made to mimic normal food as closely as possible. And this is kind of, I think, at the beginning of things really tipping off where we saw more and more literature starting to come out. So this was back in 2012. So this first survey was administered by the Ollie Foundation. The Ollie Foundation had members or individuals that had access to the Ollie website complete a survey to assess the prevalence of blenderized tube feeding. If you're not familiar with the Ollie Foundation, they are a national nonprofit organization with an active and very involved interest in helping educate the home enteral nutrition population. So 216 individuals completed the survey. The majority of which you can see were pediatric and around 42% were adults. So most of the pediatric and adult patients surveyed used blenderized tube feeding to make up more than half of their enteral nutrition intake and also greater than 50% of their total daily calorie needs as well. Individuals surveyed in both groups reported better weight maintenance on blenderized diets versus a conventional formula. So with the high prevalence of its use, it really is vital that as dietitians and healthcare providers that we expand our knowledge regarding blenderized tube feeding and that patients have access to professionals with expertise in this area so that we can help guide them on recipe development, and we can also continue to evaluate and monitor these patients who have a desire to use such a regimen. This survey was done with parents of tube-fed children in an online support group. They completed an electronic survey to compare their experience. So individuals were either using a commercial conventional product or they were doing a blenderized tube feeding. It was about half and half, so about 50% were on a conventional product and about 50% were doing a blenderized diet. So the most commonly cited reasons for using a blenderized tube feeding was the desire to provide whole foods, ranked at the top, followed by a decrease in symptoms of tube feeding intolerance. Also following that was a dislike of commercial formula. Around 12% reported that they wanted to provide something that was similar to their family meal. Around 11% cited that there was an increase in oral intake on a blenderized diet, and around 5% reported doing a blenderized diet to address allergy concerns. The reasons for not using blenderized tube feeding were around 51% reported they had a lack of knowledge of such a diet regimen for a tube-fed patient. 20% reported there was time constraints. So for those parents that were using blenderized tube feeding, they did report that there were fewer symptoms of tube feeding intolerance, and they also cited that children met their growth goals more frequently on a blenderized diet. But what's also really interesting is that, a significant number of these parents in the sample were able to successfully provide full or partial blenderized tube feeding to their children, but only half of these families relied on healthcare providers for guidance. That's kind of concerning, right? So we definitely want our families, our patients, the caregivers talking to us about what it is that they're doing at home so we can continue to properly monitor and evaluate these patients. There is a wide variability in blenderized tube feeding preparation and delivery if they're doing it on their own. So parents or patients who use or who have an interest in blenderized tube feeding really need knowledgeable and supportive healthcare providers for guidance and follow-up due to the unique nutritional needs of this patient population. Also, with that being said, more and more healthcare facilities are reevaluating their enteral feeding policies to accommodate patients on blenderized diets. So this prospective cross-sectional study was of adults using blenderized tube feeding. It is very important to note that most studies that have been published thus far have been done in the pediatric population. So in this study, there were 54 adults that were on home enteral nutrition for at least 3 weeks. The participants were provided a survey at follow-up appointments after receiving their home enteral nutrition for at least that 3-week period. Greater than 50% of those in this study were using blenderized tube feeding. Most commonly cited reasons were that it was more natural, they liked eating what their family was eating, and that they also cited better tolerance with a blenderized diet. Patients also that were using the blenderized diets reported that 80% reported maintaining their goal body weight on the blenderized diet regimen. They also cited significantly less GI symptoms compared to a commercial formula. So those GI symptoms included less nausea, less vomiting, bloating, diarrhea, and constipation. And 80% of those in this study expressed a desire to use blenderized tube feeding if they were provided with more adequate information. All right, so last of the surveys here, but this one was done in the pediatric dietetic practice group. And this was done amongst pediatric dietitians to assess their attitude and experiences regarding blenderized tube feeding. So 244 pediatric RDs responded. 58% were using and recommending blenderized diets. What the study found, or the survey found, was that the interest was largely parent-driven, or it was explored as an option for children that had tube feeding intolerance. Around 6% reported that they had recommended a blenderized diet for those individuals that had an inability to obtain a commercial formula. Perhaps they didn't have insurance coverage. 79% reported that they had an overall positive outcome with blenderized tube feeding. And with that being said, they also noted improved growth and oral intake. The reasons for not using a blenderized diet were that they reported that there was concerns of risk for bacterial overgrowth, there was inadequate time to follow up with patients, and also there was a lack of specified nutrient composition doing a blenderized diet. 28% indicated they wanted more information on using blenderized diets in clinical practice so that they could help patients and families in their efforts. So despite the widespread popular use of blenderized diets, they've not been universally accepted by the medical community. Improved tolerance historically was mostly anecdotal, but over the last 7 years, we have seen an increase in the published literature assessing the benefits of blenderized diets. So the most common concerns, one of which is the variability in the composition of blends, and also concerns for potential nutrient deficiencies or excesses. However, reports on nutrition adequacy when dietitians are instructing on the feeding composition has historically been lacking in the clinical research. Food safety has been another cited concern. We'll take a look at some studies that address that towards the end. Application concerns, again, so delivery methods, are they bolus fed, gravity, are they on a pump, the hang time of blenderized feeds, the labor involved in doing a blenderized diet, especially if they're doing it from scratch. And also there's just been a lack of data to support use and demonstrate safety. But again, like I said, with continued published literature, that is changing, and we will review that so you guys are familiar with what the most current literature is stating. All right, so we're going to take a deeper dive into some of the clinical evidence surrounding blenderized diets. So most of these surveys or studies have pointed to the need for more clinical research, not just anecdotal reports from patients or families. So the first one we're going to look at here was published in 2018 by Gallagher. So the objective of this study was to evaluate the feasibility of using a blenderized tube feeding in the medically complex pediatric population and to assess the impact on clinical outcomes as well as looking at the microbiome. This was the first prospective evaluation of transitioning patients from conventional formula to blenderized tube feeding. So there were 20 pediatric participants, 1 to 16 years old, enrolled in the study. All were G-tube dependent, receiving 3/4 of their energy needs from a conventional formula. All of the patients were transitioned over to a blenderized diet over a period of 4 weeks. And the dietitian enrolled in this study or involved was screening patients at enrollment, at 6 weeks, 3 months, and again at 6 months. 17 of the 20 transitioned over to a blenderized diet, and one of those patients was able to successfully transition over to 100% oral feeds, which is wonderful. So, in looking further at the results of blenderized tube feeding compared to commercial formula, they noted there was superior micronutrient content in the blenderized diet compared to conventional formula, with the exception of vitamin D, they noted, which is similar to eating a regular diet. They also noted that fiber did not meet adequate intake in the conventional formula group, but that this improved with blenderized diet. They also did stool samples to assess the microbiome of these patients. While not statistically significant, there was a trend for the relative abundance of Firmicutes, which is a commensal beneficial bacteria, and they found that that increased over time on the blenderized diet. They also noted that the pathogenic bacteria, proteobacteria, decreased, and they also found that bacterial diversity of the microbiome increased overall on the blenderized diet. So research has cited numerous human diseases have also been associated with a decrease in the bacterial richness and diversity of our microbiome as well. So the overall increase in this diversity may suggest that blenderized diets could be very beneficial in improving the G-tube fed patient population's health and well-being. They also cited some GI intolerance markers. So they noted that those that transitioned to the blenderized diet, vomiting decreased by 23%, gagging and retching decreased by 35%. Both were significant findings. They also noted that the use of acid suppressive agents decreased by 12%, and that oral intake increased by 13% when those patients transitioned over to a blenderized diet. They did note that caloric intake was higher on the Blenderized diet than a commercial formula. Some possible explanations that the study cited were that this could have been due to the thermic effect of feeding or changes in food digestion and absorption that were secondary to the diet-related alterations in the intestinal microbiome composition. It is important to note that most other studies have not found the same finding, that higher calorie intake is required on a Blenderized diet to meet the patient's needs compared to a commercial formula. The caregivers also reported that they perceived their child was in significantly less discomfort. They were more satisfied with the feeding regimen, and all would have recommended a Blenderized diet to other parents following the conclusion of the study. So this next study is more recent. It was published in 2019 out of Boston Children's Hospital. This study was to determine whether clinical and patient-reported outcomes differed in children that were on Blenderized diets compared to conventional formula. So it was a prospective cohort. 70 medically complex children were enrolled. You can see that 60% of those were on either a homemade Blenderized diet or using a commercially prepared Blenderized formula. 40% of those were on a conventional formula. Majority of patients were G-tube fed, but there were a smaller proportion that were on a GJ and a J-tube. Dietary intake was obtained with an interview with a dietitian and or a detailed food journal. So I included, this is a table from the study showing the different comorbidity categories of those enrolled. So there was a mix of individuals that had neurologic complications, oropharyngeal malformations, prematurity, etc. But I also like how they broke down the feeding tube types amongst the different formula groups. So I think it's long been cited in some of the old literature that G-tubes are the only compatible method with the Blenderized diet, but they did demonstrate that they were able to successfully administer Blenderized diets with GJ and J-tube patients as well. This is also the first study, to my knowledge, that I have come across that has looked at healthcare use pertaining to the type of formula an individual has been on. So the length of the study was 18 months, or a year and a half long. And they found that over that time period, over a year and a half, those patients on Blenderized diets, their total admissions into the hospital were down by 53% compared to those on a conventional product. The respiratory admits were down by almost 70%. And you can see levels of significance were met amongst most of these categories as well. So in addition to the decreased healthcare use observed, they did quality of life measures and looked at GI intolerance measures in part of the study population. So 58 of the 70 participants completed a questionnaire. Those participants on Blenderized tube feeding reported greater satisfaction ratings with their feeding regimen. They also reported fewer reflux symptoms as well. It was also cited across 3 different validated GI questionnaires in the pediatric population that there was significantly improved GI function across a number of measures. So specifically, they cited that there was significantly less nausea and vomiting, abdominal pain, abdominal upset, worrying about stool, diarrhea, and limitation to food and drink in this study. And all the caregivers also reported greater satisfaction with the Blenderized tube feeding group. So in their discussion piece, they were like, what potential mechanisms could have explained the beneficial effect on these health outcomes? So although the data showed similar energy content and macronutrient composition between formula and Blenderized diets, it was the quality of the macronutrient composition that differed substantially. So specifically, our conventional formulas use rapidly digested carbohydrate sources such as maltodextrins and corn syrup solids, whereas diets with slowly digested carbohydrates from legumes and whole grains found in Blenderized diets can help to reduce the risk of airway inflammation seen in ventilator-associated tracheobronchitis compared with standard formula. They also noted that the provision of a diet containing actual fruits and vegetables may help to reduce airway hyperreactivity or reactive airway disease. So, which is maybe why we see the decreased gagging, retching, and reflux reported across multiple studies. So in addition to the multitude of health benefits, dietary fiber, which is absent in many of the conventional formulas, but is emphasized in a blenderized diet, acutely decreases airway inflammation. And lastly, blenderized diets help to increase dietary diversity as well. And increased dietary diversity helps to increase microbial diversity. So the study that we already discussed with Gallagher demonstrated that. So they found that the blenderized diets increased the dietary diversity, which increases intestinal microbial diversity when transitioning from a conventional formula to a blenderized diet. So a diverse intestinal microbiome is associated with decreased risk of asthma, systemic inflammation, and obesity. So dietary fiber may be an important driver in this relationship, as it shapes the intestinal microbiome composition and also affects the production of short-chain fatty acids, which in turn helps to direct immune cell differentiation towards more non-allergenic phenotypes, which is important for also decreasing airway hypersensitivity. So overall, the study suggests that blenderized diets are well tolerated, they're safe and relatively low-cost interventions to improve the health outcomes in this population, with potential for significant reduction in healthcare costs. So this is a recent study published in Aspen 2020 to determine the prevalence of GI symptoms in children receiving a blended diet via G-tube. They reviewed the clinical experience with G-tube-fed children who had been receiving a standard enteral formula and were subsequently switched over to a blenderized diet. This was a single-center retrospective study. Children were 1 to 18 years old. There were 23 enrolled within the study, and they received the blended diet, and they were followed up with over a 12-month period. A pediatric dietitian was involved in the nutrient recommendations. They classified GI symptoms as either upper or lower. So upper GI symptoms included gagging, retching, emesis, cough, or concern for dysphagia or aspiration. And lower GI symptoms were classified as either diarrhea or constipation. So 95% of those patients who were previously experiencing upper GI symptoms on a commercial conventional product improved within the first 3 months after the blended diet was initiated. While on standard formulas, 91% of the participants had experienced symptoms. The odds of a patient having any upper GI symptoms decreased significantly over the 12-month follow-up period. 2 of the children were transitioned exclusively over to oral feeds, and 53% of the caregivers reported that there was improved PO intake as well. No patients within the study had any evidence for nutrition deficiencies, and none were hospitalized for suspected foodborne infections while on a blenderized diet. 21% of the population within the study developed mild constipation, but that was resolved by increasing free water intake or with use of polyethylene glycol. And the patients on the commercial blended diets reported, again, that they were well tolerated and they had improvement in upper GI symptoms. So overall, this is important to consider, the dietitian's time involved in working with patients, whether that's doing a blended diet from scratch or recommending a commercial blenderized product that's out there, could be a consideration for the caregiver or family's time. And then food cost considerations as well are another factor to consider in doing a blended diet. Where many of the commercial blended products are covered through insurance, these families are not having to pay out of pocket if they have insurance coverage. So pivoting a little bit to the food safety concerns, because this is commonly cited as a reason that individuals don't recommend blenderized diets, or has in the past been a cited concern. Johnson did a study comparing microbial growth between commercial formula and blenderized tube feeding. It's important to note that most food safety studies and blenderized diets have been done outside the United States, where the use of blenderized diets is more prevalent, and the food handling practices, costs, and availability of commercial formula vary more widely as well. So in this study, they compared, again, microbial growth of a commercial formula versus blenderized tube feeding. Blenderized formulas were prepared in the hospital and delivered to an unoccupied patient room. They found that the microbial loads of the standard formulas and blenderized tube feedings, sorry, excuse me, I got sidetracked. So they prepared those in unoccupied, or they delivered the formulas to an unoccupied patient room, and they found the total bacterial counts were well below the acceptable limits for consumption at 0 hours, 2 hours, and 4 hours. So due to the increased use and interest in blenderized tube feeding by patients and their caregivers, healthcare facilities may need to re-examine their policies prohibiting their use. It does show that if there is a judicious blended tube feeding recipe selection and there's adherence to safe food handling practices, that blenderized diets can provide a safe feeding substrate equivalent to commercial formula in the hospital setting. This study by Milton assessed a standard procedure for minimizing bacterial growth of blenderized tube feeding prepared in the home setting, whereas the previous study was done in the hospital. So 50 participants prepared blenderized tube feeding in their kitchens using a standard preparation procedure to minimize bacterial contamination. Blenderized tube feeding was assessed for growth of certain microorganisms at 24 hours and 48 hours. And they found that there was no substantial increase in microbial counts during the 48-hour period. So again, established safe food handling procedures can minimize bacterial contamination of blenderized tube feeding and consequently reduces the risk of foodborne infection in the home enteral nutrition patient population. So we've covered quite a bit so far. We've gone over surveys that have shown there's a strong interest in blenderized tube feeding. We've discussed the nutritional adequacy and superiority of the feeds, improved tolerance noted, improved symptom management, improved patient caregiver and satisfaction, and safety of delivery. The last part we haven't talked about is where dietitians ourselves are involved in patient care. So we're very critical in managing enteral regimens. Most of the healthcare providers are leaning on us to make these recommendations and to help the patients. So, patient selection, picking, which patients may be most appropriate for a blenderized diet, helping to determine the type of blenderized tube feeding that's best for them. Are we going to suggest a homemade recipe, or are we going to maybe suggest a commercial blended formula? If we're doing a homemade recipe or doing a commercial blend with the addition of some foods at home, we're helping to create those recipes. We're also there to help guide patients in the transition over to a blenderized diet. It is important often, as the case with any formula transition, that we be cautious and doing it in a stepwise manner to help with improved tolerance with the introduction of fiber. We're involved in helping ensure nutritional adequacy and safe food handling practices, delivery considerations for the patient, and then of course the close monitoring of patients on blenderized diet to ensure they're meeting their calorie needs, their fluid goals, their micronutrient needs, that they're maintaining growth goals, etc. Uh-oh. One moment, guys. I don't know what happened. It's starting back up. It just closed out for some reason. So PowerPoint's expecting it had an unexpected error and closed down. Okay. And for some reason, the slide is all jumbled now, but to continue. So homemade blends versus commercially prepared blenderized formulas. So in doing a homemade blend, we're going to recommend them doing their own blended foods from scratch, using baby foods or purees as a base, using commercial formula as an addition to whole foods. Also homemade blends historically in the literature too have been cited to be used with G-tube fed patients with a 14 French or greater feeding tube size. The hang time when doing a homemade blend is often reduced, and bolus has been cited as the preferred method for administration. The commercially prepared blenderized formulas allow for wider use. If an individual is traveling or on the road, or they need something when they're in a pinch, having a commercially prepared option already in a bag available to go can be a lifesaver. The options that are out there for blended commercial formulas work with a variety of feeding tube sizes, so not just a 14 French. Again, some of these blenderized diets can be used in more narrow tube feeding sizes, such as GJs or J-tubes. The commercial blended options also do contain available nutrient information, and some of those formulas can be used as sole source nutrition. So whereas historically with a homemade blend, obviously there's got to be a lot of critical detail to paying attention that patients are meeting their macro and micronutrients if doing it from scratch. Commercial blenderized diets are less labor intensive. It is an option to supplement homemade blends if that's what the families desire to do. And again, a lot of these commercial blended formulas are often covered by insurance, whereas food costs, if doing their own homemade blend, often is not covered through insurance. So in summary, there has been demonstrated mismatch between what the home enteral nutrition community is preferring or doing using blenderized tube feeding and healthcare practitioner oversight. We know that the involvement of the healthcare team is so vital to the success of our patients on their tube feeding regimens, and even more so if they have a desire to do a blenderized diet. More research is being done showing the benefits of the improved symptoms, nutrient quality, and microbiome health, healthcare costs, and caregiver satisfaction. And those of us working in hospitals that have contracts in place, we need to be considering the barriers to such policies and procedures that are getting in the way of patient-centered care, where individuals are coming in requesting these sorts of diets, and having the tools available or having the resources available so that we can help to meet the patients where they're at in their journey. And also really important to consider is where, this can be more healthcare team driven versus patient and caregiver driven. A lot of those surveys cited that the reason for using blended diets was because they waited for the family to request it. But enteral feeding is the only area where we as dietitians are not actively talking about the benefits of getting phytonutrients and whole foods in the diet. So perhaps having those conversations, if a patient is being discharged on a feeding tube regimen and it can't be provided in the hospital, helping those patients and their families understand that they do have options and helping to delineate what those options are. So if you're looking for additional blenderized tube feeding references or resources, the Tube Feeding Awareness Foundation and the OLLI Foundation are both great nonprofit organizations. If you've not ever visited their sites, I highly recommend that you go and cruise around to look at what information they have available. The Marsha Duncline Homemade Blenderized Formula Handbook has been around for some time, contains different recipes, and is also a great resource. And then Claire is a dietitian out of Canada, but she is a big advocate of blenderized tube feeding herself, and she's developed an online blended diet course. So look her up. She's also a wealth of information and it coming to, doing blended diets. And she's just recently launched, like I said, the online course. So here are the references from tonight's presentation. Apologies for the technical difficulties. I want to open up the floor to see if anyone has questions. And let's hope that my computer does not wig out at the last second here. No. Not gonna touch my mouse. So you guys can either unmic if you have a question, you can type it into the chat. Good Lord. Or into the questions. I'm keeping an eye out. Can you send those references? Yes, I sure can. So we've got, what time is it? 7:23. So we've got time, a couple of minutes for questions. I will give it a minute. If there's not any questions, I will go ahead and advance the slides here in just a second. I don't see any more questions or chats. Yes.
Laurel,
Yes.
this is Janice. Of course I have a question or a comment, just to say that, you know, my whole career is kind of based on blended formulas, and this is the first time I've seen kind of a comprehensive look at what literature is out there. And I think it's great. I think it's good that the hospitals are looking at it in a clinical setting, because of course I'm in pediatrics, so the families are wanting all of that. And it's nice to be able to go even to my administration. I have lots of things I'm going to take there to them to say, let's revise our policy. I have 2 exceptions over the last few weeks. I've had 3 exceptions to our policy, and I've just gotten a lot of pushback, but it's nice to know that places like Boston have done that look, and so that's nice, just in general to kind of know what's out there, and know that we should, as dietitians, we can do it. It's just like writing a meal plan. So
Absolutely. Thank you for sharing that. Most definitely. And having come from the clinical side, I used to work in the hospitals. I mean, I understand both sides of it. You know, it is challenging, and we're often maybe in opposition to what administration needs or wants are. But, you know, I want to empower dietitians in our role to feel like we can make change. I mean, carrying this information forward and sharing it with our doctors, with our clinical managers, with administrators is important to help really move the needle and to make change within the hospital setting. So I appreciate that, Janice, very much. And so I will keep an eye out as I advance the slides if there's any more questions or anything that comes forward. That concludes the CE portion of the presentation. To just go over briefly some of the products that Functional Formularies offers. Liquid Hope and Nourish are 2 of our original flagship Blenderized products. You may have heard of these in practice. You may have had families bring them in on their own dime. You may have had a request for them. But Liquid Hope is our optimized for adult formula, and Nourish is our pediatric blend. And more recently, last year, we launched peptide formulations of both the Liquid Hope and Nourish formulas. So we do have Liquid Hope peptide and Nourish peptide available as well. For those of you guys that don't know, we do have a free sampling program in place. So if you're a part of a facility that has patients that you are working with on feeding tubes that you think would benefit from trying the formulas, whether that's when they're admitted inpatient or if they're discharging out of the hospital and they're going home with a durable medical equipment company to continue their tube feeding, you can reach out and request free samples. We ship directly to hospital facilities. We can ship directly to patient homes. We're very flexible and accommodating. I understand how important formula trials are to assess a patient's tolerance. So if y'all have any questions, whether it's information that we presented or was presented in tonight's study or for samples, my email address is right here on the screen, laurel@functionalformularies.com. And that is the conclusion of this. So I thank you all for attending, and I really hope the information was informative for you guys and will be something you can take forward with you tonight and moving forward in your roles. So thank you guys. And thank you, Janice, for helping us to facilitate this. I appreciate it. Definitely. I agree, Jennifer. We've got a lot of work to do, but we need more vocal people to speak out in the hospitals. It's super important. It takes an army, that's for sure. All right, guys. Well, y'all are free to sign off. It's my computer just, I don't know, it's like seizuring here. Everything is concluded. I will send the references from tonight out as well. So y'all have a great night.
Laurel, thank you so much.
You're welcome.
It was great. It was great. I couldn't take notes fast enough. So, and I'll call you later. I have 2 patients, you know, I was just thinking about that, that I might want to do some sampling with. So,
Absolutely.
yeah. But
Happy to help. Happy to help discussions too with your the directors or higher ups within Scottish Rite. I don't know if it would help move the needle at all, but we are on one of your GPOs, which group purchasing plan. So I don't know what opposition you're getting, but we can talk about that.
Well, it's more of the food safety issue. So I was really glad that you covered that. And like, oh, we can't do, and then honestly, the amount of work. Like I have a Blenderized kit in right now, and we kind of timed ourselves yesterday or today making the formula. And it's, it's a complicated. It's too complicated to my way of thinking. But I'm going to make it while the kid's here. But because I don't believe in complicated blended formulas, and but it took us almost an hour from start to finish. And so then, in that case, you've got to have tech time. We have a very, very good tech to make formula, but that's a chunk of time out of her work. But so I'm still thinking that we should do, a commercial one. I think that's our better shot, is to do a commercial formula. And I'm going to talk to the mom about it later on this week. Well, I guess tomorrow's Thursday, so I guess it'll be Friday that I'll talk with her. So
yeah, I'll halfway through the week. Yeah, well, definitely let me know how I can help with that. We got to think of feasibility too in these patients' discharge, right? If we give them, some parents are really motivated to do blending at home, and I have no problem. I think it's great, but it does take a lot of time and oversight. And
I like the combination of using, like you mentioned about using a base of a commercial formula and then adding your own things, because then I always struggle with like home blended, getting the right kind of protein in and an easy to push formula. So I always feel like if I could use like Nourish. I have one kid that's on a blended formula, or a formula with Nourish as the base, and then some additives, and that makes mom feel better, makes me feel better, because I got decent protein. I got that lovely 14 grams of protein in that one bag. And so at any rate, but I'm just thinking that maybe at some point we can set up a meeting with our new hospitalist. Her name is Dr. Deely. She's only been here a month. And it's great working with her. She's very nutritionally involved. So we'll see if we can get set up and either do it, do a Zoom meeting, another Zoom meeting, or Teams, or whatever we need to do for that. So.
You bet. I can't wait till we're back out in person again.
Oh, I know. Yeah. Anyway, thanks so much, and have a good night. Okay.
Thank you.
All right. All righty. Bye-bye.
Bye-bye.